I'm Paul Ginsberg, and on behalf of the USC-Brookings Schaeffer Initiative for Health Policy, I want to welcome you to Brookings. Today's conference is on possible reforms to laws and regulations preventing physicians and other providers from referring patients to entities that they have a financial interest in, often referred to as STARK, from the author of the legislation, and laws and regulations that prevent providers from offering or receiving a kickback for care decisions that they make. These policies developed during an era of almost universal fee-for-service payment, and the restrictions appear to interfere in important ways with alternative payment approaches, and waivers are often granted. But we have a problematic situation when one approach to self-referral and kickbacks works for part of the healthcare system, and another part works for the other part of the system. In 2018, the administration sought stakeholder feedback on how the regulations implementing these laws might be modified to promote value-based, coordinated, and integrated care while still protecting taxpayers and beneficiaries from fraud. HHS Deputy Secretary Eric Hargan has worked with these issues and thought about them for many years. He will open the event with his keynote presentation. After the Deputy Secretary speaks, he will take questions from the audience. Note that the question should be limited to the STARK and anti-kickback issues that this event is about. After that, my colleague, Brookings Fellow Kristen Link-Young, will moderate a panel discussion on these issues with experts in healthcare payments and delivery system reform. I'm pleased to introduce to you and welcome to Brookings Eric D. Hargan, Deputy Secretary, U.S. Department of Health and Human Services. As Deputy Secretary, he is the Chief Operating Officer and is responsible for day-to-day operations and management of the department, in addition to leading policy and strategy development. He served in a number of senior positions at HHS during the George W. Bush administration. Mr. Secretary.
Thank you for that introduction, Paul, and thank you to Brookings for welcoming me here today. Thank you to everyone who's joined us here for this important event from both inside and outside of government. I know there's nothing that sets hearts aflutter in this town quite like a think tank event with a long speech and a panel on rewriting obscure regulations. So welcome. But quite seriously, today's event and topic is tremendously important. I'm glad to have Brookings recognize that by holding this discussion. Back in October, Secretary Azar was also here with Paul and the USC-Brookings Schaeffer Initiative to deliver a speech on the model HHS put forth last fall regarding prices in Medicare Part B. He noted that reform to how Part B pays for drugs has been a very long time coming, a place where for a long time everyone across the policy spectrum has agreed that we need changes. The pharmaceutical marketplace has changed to where more and more expensive and complex drugs are playing a bigger and bigger role in our healthcare system, and yet our payment systems aren't set up to drive competition or negotiation in these new corners of the prescription drug marketplace. Now, we recognize that something similar has happened with the market for healthcare services, but here the policies we set at HHS are even more important. Outdated policies from HHS mean not only less than desirable results for taxpayers, and for beneficiaries of our programs, but often for patients and payers in the private market as well. The role played in paying for services by our own policies at HHS is dominant, which means that where we aren't innovating, we hold things back. Just about all healthcare experts agree on where we want to go. We need to be moving our payment system from volume to value. I imagine that the health policy scholars at Brookings aren't even allowed to sit down at the lunch table unless they've already thought about volume to value that day. Sure, Paul enforces that. But it's important to recognize what this all means. Those of you up on the issues, especially the lawyers, know we're not going to move from volume of referrals to value of referrals. What we're considering is something that is much different from that. Really, under one way or another, this is the third administration to work towards the goal of value-based care, under whichever rubric they placed it under. What, after all, was Part D that I worked on under the Bush administration, or the revamped Medicare Advantage, besides ways to drive value through competition and incentives? I worked on the medical severity, DRG reform back then as well. That again was something that is value-based effort in some way, even if it wasn't placed under that particular banner when we were there in the Bush administration. And at the same time, moving in that direction towards value hasn't been all that rapid. Private actors have been innovating. HHS has as well. For example, from 2017 to 2018, the share of Medicare beneficiaries in alternative payment models went from 13% to 17%. That is progress, which we acknowledge, but it's still under 1 in 5 Medicare beneficiaries in those models. Now, part of the reason moving to value has been slow is because it requires a radical reorienting of how American healthcare is paid for and how it's regulated. That means we have to take a holistic view of all of our policies and programs in order to push the transformation along, and that's what we have done at HHS. In particular, the topic we're here to discuss today, regulation, is vital. It's one of the several significant ways I've been working on the move from volume to value at HHS, alongside health IT, payment innovation, and others. Now, I will confess I'm glad to be here at a think tank event like this because it's a little easier to get the crowd excited about a discussion on regulations. In my previous tour of duty at HHS, I served as the agency's Deputy General Counsel for Regulation, as the Regulatory Policy Officer, and as the Chief Regulatory Officer of the department. Now, in my return to the department, I get to be the Chief Regulatory Officer again. I've also taught administrative law and healthcare regulations as a law professor at actually Loyola Law School in Chicago, alongside my fellow professor, Kim Brandt, who's here today, and worked as a regulatory lawyer at my former law firm. So, regulatory reform, I think it's fair to say, I think you'd all agree, is a personal passion of mine. At least that's how I've shown it. One thing I'm proud to note is that over half of the regulatory savings for the entire administration in 2018 were achieved at HHS alone. We were #1 among all agencies in both the number of deregulatory actions and in regulatory savings in 2018. So this is personal to me, and I can get frustrated sometimes that regulatory reform is too often viewed as a giveaway to industry, which is not what it is at all. Done right, regulatory reform like this is an opportunity to examine the barriers that regulations create between market actors and determine how we can reshape those barriers or reduce them so that new arrangements, relationships, and solutions can emerge, all while maintaining safeguards for innovation, competition, patient access, and the sound use of taxpayer dollars, all of which are focuses of ours as we move forward on this reform. We have to keep in mind all of those things that act as kind of the guardrails on the reform as we move it forward. In healthcare, this effort is all about giving patients, providers, and payers new freedom and the right incentive structure to forge solutions to the challenges that we all face. The rising cost of healthcare, first and foremost, but also questions of access to care, the burden of chronic disease, the neglect of mental health care, and so much more, all of which are implicated by the current structure that we have in place right now. Many of these things are restricted by the system that we have in place right now. The use of alternatives, the burden of chronic disease, which can't be addressed in many ways because of the system we have in now, the fact that we don't have mental and behavioral health care systems in place, in many ways are implicated by the regulatory system that we have in place right now that I and the panel will be discussing today. In recognition of how important regulatory reform is to healthcare, I launched a project we've done, the Regulatory Sprint to Coordinated Care. And that brings me to the topic of today's event, in particular, efforts around the Stark Law and the Anti-Kickback statute, because those are two of the 4 areas we've initially chosen for the regulatory sprint, alongside HIPAA and another privacy law called 42 CFR Part 2, which is a privacy law that's around substance use disorder primarily. So 2 of the laws that we're working on for the regulatory sprint are deal with affiliations and structures, and 2 deal with information sharing. So we've got, the 2 we're going to talk about most today, Stark and Anti-Kickback statute, both of those are dealing with how different organizations in the healthcare space affiliate and deal with each other. Each of the words in this initiative are deliberately chosen. It's a sprint, sprint from a governmental point of view. Okay, so let's not get overly excited here. We are intent on gathering the information we need and moving to rulemaking as soon as possible. And I think we have been, from a governmental point of view, I think we've moved very rapidly, because the Americans' need for healthcare reform really cannot wait. So sprint, so chosen. It's about coordination. Above all, this is not an ordinary regulatory burden exercise, but it's squarely aimed at understanding a particular problem, how regulations are impeding coordination among providers that can provide better, lower-cost patient care, and reforming the regulations consistent with the laws that are on the books and their intents. Finally, it's about care. Regulating health care means regulating some of the most intimate decisions and relationships in our lives, deciding where and when to seek care, how to make decisions with our doctors and family members, and more. And we believe that this effort can meaningfully improve the quality of care received by American patients. And I will add regulatory, the regulatory sprint. Regulatory is also important here. This is not a legislative effort. The laws remain in place as is. This is a regulatory effort undertaken within the administration. So this is an interpretation of laws, but it is not an effort to change those laws. Those are undertaken by Congress. I don't lobby, prohibited from lobbying. I'm in Article 2, the executive branch. Not going to get into that issue at all. Now, I should note examination of these laws, the Stark Law and the Anti-Kickback statute, really began before the regulatory sprint itself. The President has made regulatory reform one of his key drives, and the aggressive attitude of his administration toward regulatory reform predates when I became acting Secretary of HHS in October 2017. Earlier in 2017, through its annual payment rules, CMS asked for comments on improvements that could be made to the healthcare delivery system to reduce unnecessary burdens for clinicians, other providers, patients, and their families, including ways that those burdens might be impeding care coordination. Now, in response, we got a great deal of input to the barriers to participation in care delivery and in payment reforms, both public and private, as well as the burdens of compliance with the Stark Law and other regulations as they exist today. So kudos to Secretary Price for enabling that. But of course, it did not stop there. The drive towards coordinated care gathered new steam under Secretary Azar because the importance he has placed on driving towards a value-based system, which is one of the 4 priorities that he has as Secretary. Underneath value-based care, there are several legs. One of those is coordinated care. And the drive to coordinated care provokes some obvious questions that point towards the need for broad-based regulatory reform in this area. Some of the questions and challenges that we got along the way were things like, how can we expect physicians to act as navigators of the health system while also holding them accountable if their decision-making is hamstrung by outdated regulations? Or how can we expect providers to get on board with payments based on outcomes if we're not willing to give them the freedom to experiment and coordinate with one another? Why would they want to take on risk unless they feel they have the tools they need to improve outcomes? How can we really make major steps in preventing and curing disease without also rethinking how regulations like these could impede patients and providers working together in creative arrangements where everyone is incentivized to keep people healthy and out of the highest cost settings? So the regulatory sprint is really at the heart of our value-based efforts. In fact, in the very first speeches Secretary Azar gave last year about how he views value-based care, just under a year ago, he identified barriers to coordinated care as one of his top priorities. Now, another way you can tell we're serious about the regulatory sprint is, of course, we have a Twitter hashtag. That's RS2CC. It's simple, it's brief, just like we'd like to make our regulations to the point. So now I want to discuss exactly why we think there's a need to consider the Stark Law and the Anti-Kickback statute. Now, I say this as an attorney where these laws were probably my most significant area of specialization. I am sympathetic to what the laws stand for, as we all should be. Rightly reformed, the exceptions and safe harbors within them can be reoriented, I believe, to help us transition to a new paradigm of value-based care. So, what would this look like for each law in particular? Take the Stark Law. When enacted in 1989, again, 30 years ago, the Stark Law rightfully addressed the concern that inappropriate motives could distort decision-making in healthcare. It recognized a worry that some physicians might order services based on their financial interest in service providers, rather than the good of the patient. In a largely fee-for-service context, you can see why that would make sense. It's relatively easy for a doctor with a financial interest in another provider to say, drive their patient towards those places to add on extra money. In a fee-for-service context where you're paying service by service, this law was intended to operate as a brake on that tendency. And the law clearly was passed with good intentions, and it was and is responsive to the structure of fee-for-service care and the incentives that involves. The heart of it is ensuring that a patient has options for quality care without regard for whether a physician has a financial interest in that care. We don't want people referred to services they don't need or steered to less convenient, lower quality, or more expensive healthcare providers because of their doctor's financial interest. Now, of course, it's worth bearing in mind the larger context. Fee-for-service, the inpatient prospective payment system, was and is a reform that responded to poor incentives in the previous system, which reimbursed based on reasonable cost. So we keep sort of going through iterations of this, at each time attempting to kind of have an overall improvement. But in some ways, we've seen sort of the light towards the new system that we have, and we have to lay down the tracks towards that system. The Stark Law dealt with the incentives of fee-for-service in two specific ways, as I'm sure many of you know. First, it banned doctors from referring patients for certain designated health services payable by Medicare to an entity in which the physician or any immediate family member holds a financial relationship. Important term. Second, it prohibited the entity from filing claims with Medicare or billing another individual, entity, or third-party payer for those referred services. The restrictions are absolute, just with certain enumerated exceptions. But the law grants HHS, importantly, the authority to carve out exceptions for financial relationships that do not pose a risk of program or patient abuse. Now, we believe that the exceptions that may make sense today, 30 years later, probably look a lot different than the ones when the law was passed. Certainly, our healthcare system looks a lot different than it did in 1989 when Stark came into being. When you had a purely fee-for-service system, you think really hard about who is deciding who is getting paid those fees for those services. In a system where we're paying for value, where the provider ideally is taking on some risk for outcomes and cost overruns, we don't have nearly as much need to interfere with who's getting paid for which service. The government and the patient are paying for outcomes, not for individual services one by one. Of course, in considering changes to the Stark Law, we actually have to remain acutely aware of the need for competition in the healthcare marketplace. And in an ideal world, we can do both at the same time. We can promote coordination and competition. They don't need to be at odds, but we have to carefully balance those in our thinking on the issue. Now, in some ways, as I well know, existing laws incentivize coordination through mergers and acquisitions. For example, if a hospital can only incentivize a physician if he's employed by the hospital, then the rational response may be for hospitals to buy up physician practices. And and that's just one example of how the playing field is really set by these laws. They incentivize certain ownership structures and willy-nilly. It's under the idea of preventing abuse, but it really does end up reshaping the landscape of American healthcare and who owns what and who has incentives to own what. We want our regulations to be agnostic about ownership as possible. So last year we conducted a major request for information on the Stark Law, which closed in August. We received approximately 3,500 pages of comments. Now, this wasn't one of those RFIs where we get 100,000 form submissions. Not that there's anything wrong with those, but these were by and large very thoughtful and very interesting comments. I've been reading some of them myself. We have Kim Brandt here from CMS, who's been leading the charge on this and who will be on the panel later. At 3,500 pages, I assume she's read every single one of them. Right, Kim? She's glazed over. 3,500 pages later, and again, these were not as I say, form comments. By and large, these were very thoughtful, intelligent comments that we got. So this is a very complicated process, to be honest. And we'll get to. Don't worry, Vicki. We will get to the Inspector General's role in this. I'm starting with the Stark Law, but we got a lot of very thoughtful comments in this process, which was gratifying for having launched the RFIs. Was to get the level of comments and the seriousness with which the kind of community took this process, which is great. It was a meaningful set of inputs. It reflects a long-standing desire to examine these laws and the stakes surrounding any changes we make. We received comments from a wide range of stakeholders, including individuals, rural interests, integrated systems, and industry associations. It's clear how much appreciation there was for the opportunity to submit feedback on these rules. There's a shared recognition that something has to be done about them as we move our healthcare system from volume to value. Most commentators believe that regulatory changes are needed to support the move to where we want to be on value-based payment. But there was also the recognition, a recognition that we share, that there is a potential for program integrity vulnerability or other abuses. That is a significant threat that cannot be ignored. Again, we're looking ahead. We're trying to lay down the tracks to a value-based system. But we cannot ignore the current fee-for-service system, and the reality is that it will be around in some form or fashion for the foreseeable future. It is the majority of the system right now, but it has a smaller and smaller percentage yearly of the overall market. And we need to lay down the tracks from a regulatory point of view that gets us where we don't inhibit that transition willy-nilly by leaving in place regulatory system that does not help or facilitate that coming into being. So we look forward to moving ahead with rulemaking on the Stark Law soon, and the same goes for the Anti-Kickback statute, which I'll discuss briefly. Our Office of the Inspector General issued an RFI on the Anti-Kickback statute last summer as well, the comment period for which closed in October. Now here too, we're going to be very attentive to the need for program integrity. But in a system where we want to pay for value in part by giving providers more freedom to innovate, we have to look at current interpretations of the Anti-Kickback statute. Now, some of the questions and reflections I told you about, sort of what we had heard somewhat on the Stark Law, some we have heard include how can we expect a provider to improve outcomes for, say, a patient who has a poor track record of not showing up for their appointments if we're not willing to look at how patient can get assistance in transporting them to those appointments. How can we encourage patients to take more ownership of their own health care without thinking about providing them, maybe free of charge, with patient-empowering technologies, heart monitor, tablet, something else altogether? And here I'm not really talking about the government per se, but about even private actors in this space and about their ability to provide these things. And again, I'm not prejudging these things. These are just questions that have raised. They're open issues about what we're going to do or allow to be done in this space that both gets to the heart of the law that has to be enforced and also allows the new system to come into place. Now, in both the Stark and Anti-Kickback RFIs, we received a lot of ideas, some good, some possibly a little too radical to pursue without having more meat on developing areas like defining a value-based arrangement or new program integrity measures. So we're going to have more definition around this space, but we got a lot of great ideas. As I mentioned, this is a sprint. So we have a lot of ideas, many of which I'm hoping, if we have time, that we will be able to have a round two, possibly, if we can achieve that. We look forward to hearing comments and thoughts from stakeholders in the NPRM process. So once this is done, we'll have a rule that's going to be announced in this area. Notice of proposed rulemaking that will go into OMB. That's when you all will see it sort of. That's when it will pop up on the ROCUS system, and you all know that it's out there right now. We're currently in kind of the very sort of fermenting stage of development of the rule, but we're very far along, I would say. So I'm not prejudging what our team comes up with, but we are taking the questions and challenges that I was just talking about very seriously. The final area I want to touch on is that pertains to coordinated care, also dealing with payments within CMS's Center for Medicare and Medicaid Innovation, or CMMI. As you know, Adam Bowler, who's the head of CMMI, is also the Secretary's advisor on value-based care, so he kind of wears two hats. So you know that CMMI is going to have a big role in our drive towards value. Now, in creating CMMI, Congress saw the need to give the Secretary authority to waive the Stark and Anti-Kickback rules. Waivers have already been put in place for use in the Medicare Shared Savings model as well as in CMMI models, in the Medicare Shared Savings Program as well as CMMI models. Now, these coordinated care models are already proving successful in reducing costs, improving delivery of care, and we believe with the right kind of bold experimentation, we can start seeing even bigger savings and improvements. Now, we had a huge number of providers who have applied to participate in these programs and a lot of success. There's enthusiasm out there for real innovation in healthcare delivery systems. And so I want to end on a note of optimism. Looking at reforming particular regulations can sometimes feel like you're thinking pretty small. It's complex, it's often unsung and unglamorous work. But consider some of the roles that, say, incremental innovation plays in any system. The internal combustion engine hasn't changed in many fundamental ways, but over time, changes add up. I personally don't want an engine in my car from 1985, much less 1925. That system is pretty much the same fundamentally as it was 30, 40, 50, 80 years ago, but certainly they're not the same under the hood as they were before. Sometimes we have to think in these ways. We have to think about all of the areas that we're looking at. From the outside, it seems small, but when we think, when we get through this work, we know we will have had reform. We no longer hold back innovation in our healthcare system, and then we can dream big. We all dream of a world where American healthcare is incredibly high quality, but competitive, affordable, accessible, and patient-friendly. And we can all agree, I think, that we don't live in that world today. To get there, we have to do everything we can so that healthcare can function with the same levels of competition, transparency, and choice as any other market. Thinking about the topics we're discussing today will be a vital piece of getting there. So I encourage you all, bring your ideas to us. There is no idea that is too big or too small for this. We have some big ideas that were proposed, some of which I anticipate will end up in our reforms. And there are an awful lot of small ideas that we got, which are very worthy, and which, as I say, in the accumulation of them, are going to result in big reforms and big changes. So we're looking at both of these things, not just trumpets blaring, here's a large reform, which we may well have. But also there's a variety of other small things. I just want to level set for what this is exactly in the endeavor that we're undertaking here. It is a sprint. It is something that is going to focus on what we think are real achievable goals that we can get in place really this year. And the earlier the better in this year, given that we have to coordinate across departments and across the entire administration on this once we get the rule done and out. And of course, there will be another shot at commenting on the proposals when we eventually do put them forth, and so please weigh in on them as well. We want to hear what we're doing right as well as what we're doing wrong in this endeavor. So I think we can take significant strides bringing our HHS programs and rules into the 21st century and deliver Americans the kind of affordable, high-quality 21st care they deserve too. So thank you very much for having me here today. And now I have time for a few questions on the regulatory sprint, if you have any.
Hi, my name's Rachel. I'm a healthcare reporter with Politico, and I was curious in doing the Stark Law and the anti-kickback reforms, if you guys are planning to address social determinants of health. That's something I was hearing from providers and being interested in, like giving gift cards to help people pay for food or helping pay for internet connectivity for people who could benefit from telehealth.
Sure. So with regard to any specific issues, like any of the particular issues like gift cards or those, can't kind of talk about those. We're in policy formulation like right now and rule formulation right now. The question of social determinants of health is a much broader issue. It is a very wide net. So there's many different ways you can look at it. The phrase can mean anything from sort of healthy communities and social structures to the sort of no wrong door approach that you often see that's characterized the sort of integration of healthcare with social services, which Secretary Azar has talked about as well. And it can focus on sort of the sprint itself and how we enable the private sector in many ways to sort of help provide services, whether it's gift card or whatever is come up with out of there. So again, I'm not prejudging what the teams come up with in here. That's obviously an issue that people have spoken about in the space, have been talking about for quite some time. But I think we got a lot of proposals in. They're in the sort of pretty final stages within the department, I think, and the agencies of kind of getting a rule together that's going to address both of these things. A complication of which is the fact that we're endeavoring to make sure that the Inspector General's office and CMS are coordinated on the drive for coordinated care, which takes its own level of meta coordination between the agencies so that they get there. They aim at the same targets in this space. So with response to any particular areas, whether it's gift card, transportation, nutrition, there's a lot of things that have been proposed in this area under the rubric of social determinants of health. But I think we're undertaking a lot of efforts to kind of understand that area and have meetings on the social determinants, but it can be a pretty broad area depending on who you talk to in that field. It's everything from community structures and family structures to, as you're pointing out, things like the integration of social services to particular issues like gift card, which are, then there's the Sprint and then there's gift card. So there's a lot of things packed into that. But we're not going to prejudge anything that the teams come up with on a particular case like that. Yep.
Hi, Jacob Rich, Reason Foundation. So HR 6 had language that suggested substance use disorder diagnoses would be voluntarily shared with patient consent. So how will your regulatory reform affect that?
Well, Stark and Anti-Kickback is going to be separate from what we do on 42 CFR Part 2. So that's what I think you're pointing to there is the privacy issues dealing with substance use disorder and kind of how that is. That's obviously an open issue. That's why that's part of the Sprint, is because we've had an awful lot we've been hearing an awful lot of problems from people in this space about balancing privacy concerns and also care in that area, where we have a lot of areas where you have literally dozens of releases being gone back and forth between care providers in a particular community, the legal issues, and really the time constraints that it places on people who are trying to get access to care is a real issue. That is SAMHSA, and that is going to be sort of the information sharing pieces with HIPAA, which has a current RFI outstanding, I think closes next month on that, and SAMHSA, so Office for Civil Rights is overseeing HIPAA, and then SAMHSA oversees 42 CFR Part 2, and they're going to stand out their own proposals on the information sharing side. And so I think we'll be able to address those a little bit. We may have another session on the Sprint and another set of presentations on the Sprint, but on that side of the information sharing side of the house, as opposed to the affiliations and structural reform that we're dealing with on the Stark and Anti-Kickback side. So we'll have to wait on that one. But we know that we've heard the concern, certainly. Yep.
Hi, I'm Marcia Simon. I'm a consultant and do most of the work in this town, I think, on non-emergency medical transportation. Mm-hmm. So I was very pleased to hear you mention it twice in your remarks. And could you talk a little bit more about transportation? Because it does seem that the agency is moving in a lot of different directions, both with respect to, on one hand, moving to allow states to drop the benefit from Medicaid. At the same time, CMMI is looking at it in the ambulance context and elsewhere in a program integrity context, trying to get people going for dialysis out of ambulances.
Right. So transportation is obviously a live issue in this area that covers a lot of different areas. I mean, we're going to try to make sure we thread the needle so we don't have conflict between the different initiatives that we're moving forward in the same area. Again, there's a certain underlying desire, as you've seen. The administrator at CMS has talked a lot about state flexibilities paired with accountability. That's kind of one of the themes underlying a lot of the reforms that she and the Medicaid team at CMCS is undertaking at that agency. So they're trying to allow there being a lot more flexibility. That's obviously, and it goes in a different way than private actors offering transportation. But it's not in conflict. I mean, those two things are not in conflict by saying a state may or may not, a private entity may or may not. Those aren't in conflict. They're simply allowing more freedom for innovation. In some ways, the idea that we cover transportation, again, I'm not going to second guess where the administrator or the states go in terms of offering those particular services. I'm anticipating there's enough public support behind some of these things that I don't know where the states, any particular state, would go if they were offered the flexibility. I think, though, you can see that there is a theme there. They're not necessarily in conflict, although I think I get your point that there are people who want to get more transportation. See, yeah. Yeah, and social determinants of health, again, it can encompass a whole host of things. I mean, as I say, anything from the huge issue, which I've had stakeholders in to talk to me about the very broad issues which deal with communities, families, social structures, and sort of general social dysfunction, which is certain social determinant. They say, then you pack it down to transportation, nutrition, and a whole host of issues that surround healthcare but aren't necessarily seen as healthcare per se and aren't covered in a healthcare services program, but which people say this is important. Or they're matters of public health generally that broadly conceived. That's another pack. Again, Secretary's spoken on that, on sort of the issue of how we thread those things, which I think Florida calls it no wrong door. There are other states that have initiatives where you're trying to make sure that programs that are intended to help the same person don't end up getting, you have 20 different numbers for a same person to access 20 different programs they don't know about. Those are other initiatives, some of which are harder to solve than others. Yep. I could go on and on, but I'll stop there. Yep.
Hi there, my name is Rachel Kors. I'm a reporter with Inside Health Policy. So we're talking about reforms to Stark and Anti-Kickback. Senators Cassidy and Warner introduced draft texts, or they released yesterday, talking about how they want to, reform or make changes to Stark and Anti-Kickback to facilitate outcomes-based or value-based contracts for prescription drugs. Mm-hmm. Is that something that you're also looking at?
So again, I'm not on the legislative side for this, and so that kind of analysis we really are focusing on. We're to get this done, kind of Capitol Hill, and the legislative side will be a totally different set of reforms, and hopefully they'll all be in accord with what we do on the sprint. That the kind of things that we end up reforming in this space will be completely in accord with the general tone and tenor where I think everyone wants to go in this space. Not everybody, but a significant number of people want to go, probably the majority of people that are work in this space want to go here. So hopefully that's additive to what we're doing here on the services side. Yep.
How do you deal with the maldistribution of health care? 60 years ago, Louisiana had the worst outcomes in the country. Today, Louisiana has the worst health outcomes in the country, with maternal mortality 3 times higher than the average, and worse much for the African American community. If you have transportation, you'd like to have doctors to go to and facilities to go to. So how do you deal with that? There hasn't been a change for 60 or more years.
I don't know that what I'll discuss here, the panel will deal with kind of maldistribution of healthcare. I mean, I hope that whatever we do in reform will, help healthcare generally speaking. So, but I think that would be a topic for a completely different panel about that issue.
You mentioned thank you. Hi, Riley Swinehart with AdvaMed. My members are primarily interested in anti-kickback statute reform, and we understand that because there's a criminal law component to that there needs to be coordination with the Department of Justice. Yep. You mentioned in your remarks about rulemaking that you are looking to coordinate with other agencies. Yep. Can you talk a little bit about any steps you've already taken with regards to DOJ? We
have wound everybody. Part of it is just generally. The government is going to undertake, once we send it to OMB, they will undertake to hand it around officially to the other departments that have equities in here. Pretty obvious DOJ has equities in something here as an enforcement agency. However, we also have an internal enforcement agency, the Inspector General, who is actually looking and helping formulate, drafting these sections. So I know that DOJ and the IG have close relationships, and I believe that they've been talking to each other, not like, here's a draft, make comments yet, but the idea of like an overall formulation, I think we've been coordinated just internally and also to some extent externally, although there's a lot of work to be done here, and a lot of it I think requires the people involved to be sitting down and working through it. But there has been some coordination done, but there will be official coordination done at the end of this. So when OMB gets it, they farm it out to everybody who has equities. I'm going to say probably DOJ is probably the largest player for this particular project that's outside HHS. So we'll hear from them. I can pretty much guarantee that for sure. Okay, I think maybe done here, but thank you all. Thanks for the good questions, and wish us luck. Thank you.
Thanks for watching. Be sure to like and subscribe for more videos from Brookings.